I'm Dr. Goran Stankovic, interventional cardiologist from Belgrade, Serbia, and it's pleasure and privilege to moderate a roundtable discussion, ultra-low contrast, new skills and technologies for the next frontier in PCI. Here are my conflicts of interest. Elective PCI activity is reduced currently due to COVID pandemic. However, patients presenting with advanced CAD progression and higher incidence of comorbidities are coming, making cardiovascular management in this population very challenging. So we really need new proficiency in specific skills, and we also need innovations in technology in order to change the landscape for planning and performing much more complex PCI procedures. We also know that giving higher amount of contrast may impact the risk of acute kidney injury, and this is a large CAT-PCI registry with 1.3 million patients who underwent PCI, which showed us that every incremental 75 milliliters of contrast use increased the risk of acute kidney injury by 42%. For that purpose, we believe that in patients with advanced chronic kidney disease who require revascularization, either a contrast-free or ultra-low contrast PCI may safely be performed if we use the guidance from intracoronary imaging and physiology with high procedural success and low complication rates. In order to do that, we will discuss contemporary technologies like dynamic coronary roadmap, IFR and IVUS coregistration, as well as stent boost life. Following these introductory words, we will start with presentation, a role of imaging and coregistration in patients with kidney insufficiency by Professor Dariusz Dudek. Professor Javier Escaned will talk about technological developments facilitating ultra-low contrast PCI. Dr. Billal Patel will talk about IVUS coregistration in multivessel disease in left main stem bifurcation. At the end, we will all discuss the most important tips and tricks in order to help you establish the practice of ultra-low contrast media use in contemporary PCI practice.
So welcome to PCR e-course. I'm happy to share our experience from Krakow and from our teams with the use of coregistration and patients with kidney insufficiency. How can we limit the contrast use? So we know very well that the contrast-induced kidney injury is a serious complication of percutaneous coronary intervention. And we have now the opportunity to use new techniques and coregistration methods, including the imaging and also functional assessment, and also including the concept of zero contrast use to provide better safety for our patient with renal insufficiency and not necessarily only with renal insufficiency. I would like to present the first case that for me, the ultrasound is becoming more and more important. And as many cardiologists are used to rely on angio, according to my experience, I rely more on ultrasound imaging, on OCT, on functional assessment, and not only on fluoroscopy. I think that this is very important to improve the safety and also to limit the contrast use. The case is of 71-year-old male with non-ST elevation acute MI with the complex intervention done within the left main and circumflex in another hospital. The intervention was recognized as a successful. However, patient was with recurrent symptoms of angina over 2 weeks, and he was after previous bypass surgery. The issue was that patient was with many comorbidities, and also the previous intervention within the circumflex, and also the referring physicians, they said that this patient is renal insufficiency, and they are not able to recognize the problem and the reason and how to find the way of the optimal treatment. So we decided to admit a patient to our department, and this is just one recording with contrast in terms of having the co-registration, having the roadmap, I would say, for wires, how to put the wires and how to put the ultrasound, because I was not expecting to find the problem with the fluoroscopy, but rather to find a problem with the advanced imaging using, of course, the low amount of contrast. This was the example of co-registration when you have the fluoroscopy just recording and you have the ultrasound pullback, when you can easily see and refer the point on angio to cross-sectional ultrasound picture. And you see the previous stent, which was expanded in circumflex, but we are going to proximal part of the left main and circumflex when the previous intervention 2 weeks ago happened. And you see here the loop of the short loop within this left main, and clearly we see that stent implanted in the previous center is not only not well expanded, but we see 2 lumens. So certainly, probably it was some mistake that the stent is not in appropriate expansion, not appropriate position. So how to do? Of course, you can do multiple injections with contrast and trying to find, but if you have the ultrasound and you have the co-registration and enhanced imaging with the enhanced border of seeing the stent struts, you can easily navigate with those technology without contrast. As you see, the guide wire, the guide catheter is approaching with 2 guide wires, and we are trying to find the optimal access to appropriate lumen using wires and ultrasound to check that we are inside of the appropriate lumen. Here it was the confirmation that one of the wires in appropriate position. It was checked with ultrasound, and for more traditional users, you can see also the loop wire to convince you that we are in the appropriate lumen. Then when it was checked with those advanced methods, still, I would say, not using contrast, we can be sure that we are in the appropriate finding and appropriate diagnosis, and we know how to proceed. Then it was easy to decide that the reason for the recurrent chest pain probably was under expansion and not appropriate positioning of the stent. So that's why now you see the post dilatation with 4.5, 15 millimeters long balloon with 16 atmospheres. And of course, again, you don't need to use the contrast. You can rather go with ultrasound and to check your result if the stent expansion is good or bad one. So this is the technique of the grayscale ultrasound supported with the chroma flow. So in the chroma flow, you have the assessment that you are in the appropriate lumen, and still you see some under expansion. So you can use additional post dilatation, but you don't need to use a fluoroscopy with contrast, but rather only fluoroscopy to guide you and to see more details in ultrasound. So finally, the additional inflation was done with the higher pressure. And then again, you have the final confirmation of the ultrasound, and you don't need to use any contrast media. And now you see that we are in the appropriate lumen, the stent expansion is well, and we are just at the border of ostium of the left main, and it's good result. So this, I would say that the last injection is only for the documentary reasons, just to confirm that we did our job, because in other case, I would say that ultrasound is enough for me, and especially the co-registration method when you are starting to plan your procedure is very useful and helpful for such kind of interventions. So I would say that the angio and ultrasound co-registration may allow to enhance diagnostic options and improve guidance for stenting. It could be useful for these difficult cases with patients with renal insufficiency. However, we have even more techniques for more complex intervention and more complex patients. This concept is zero contrast PCI concept, when for patients like that one with the very low ejection fraction and with the renal insufficiency, we don't want to use contrast almost at all. So you see this just the baseline angio, the complex right coronary artery, and then you have the stenting of the mid and proximal right coronary artery. And here you see the technique of zero contrast. So you have the ultrasound probe tip at the proximal stent marker when you are sure that the positioning is appropriate on two different wires. One is with stent, the second one is with ultrasound. You are just checking the position of your stent with ultrasound so you don't use any contrast. And then when you are sure you are starting to deploy the stent, and then you are just taking out the ultrasound before the final expansion of the stent. And you can see that you can achieve such result without using any contrast and only for documentary reason, I would say with baseline or at the end. So those techniques are very important for especially even ostial stenting like left main I presented or the right coronary artery stenting, and could be used for patients to avoid the acute kidney injury. However, I would say that we should consider to use for majority of patients because we want to protect our patient against radiation and against contrast injury of kidney. I would say that it's not the end of the journey. We rather are more and more incorporating not only angio, but ultrasound and physiology. And tri-registration is a very interesting tool. You can see with the one contrast injection, the roadmap for ultrasound as I presented, but also you can add values with IFR and to map physiology and anatomy and making the appropriate diagnosis and decision. I would say that this tri-registration method is very useful for everyday practice, and I would say that this advanced imaging is very helpful for the strategy of PCI, providing safety and providing the better, I think, outcome. So in conclusion, I would say that we can safely perform PCI using the co-registration of imaging and functional modalities to limit contrast used to prevent kidney injury. Even if we want to reduce more contrast, we can use so-called zero contrast concept of PCI. And this is especially, of course, important for patients with renal insufficiency when we don't want to use contrast almost at all. And the present techniques, I would say that it should expand to everyday practice with PCI because it is not only for those patients, but I think that if we protect any patient with contrast and against radiation, it will be all the time better. So now it's time for better imaging and functional assessment and guiding of our procedure with more advanced techniques than only with fluoroscopy. And I think that this is current and near future for us. Thank you very much.
Dariusz, thank you very much. This was a great presentation. We really enjoyed and we learned from you. Tell me, you discussed co-registration in this specific acute kidney injury prevention. Do you use it routinely, and how much co-registration actually has impact on your regular cathlab work?
I think that I presented one of our many cases, and I think that when I do more complex cases and not only the simple one, I would say that those methods are more and more important for me. Because in the previous time, I spent a lot of contrast injection and looking at different projections of angio. But nowadays, I like to inject one contrast to have the co-registration with IFR and ultrasound, and to have the full mapping of functional assessment and having all spots with important lesions in terms of the ischemia driven approach. And also I have the same time ultrasound mapping, so I know how to fix it. So let's say that with this co-registration, I know which lesion is important, so where to treat, and with ultrasound, how to treat. And after my procedure, I know with ultrasound if I did a good job in terms of the morphology, stent expansion, and stent position. And also even I can check with, again, with IFR, my functional outcome, being sure that I don't have any problems with ischemia. So I think that those methods should be the standard of care in near future in majority of cases, especially complex one.
Yes. Thank you very much. This was great.
It's a pleasure to be sharing with you some views on this very important topic. These are my conflicts of interest. Now, why performing ultra-low contrast interventions? I think that we are bound to do this much more frequently given the shifting profile of our patients. We are seeing more and more complex patients, either because they have a clinical profile, for example, with chronic kidney disease, or because we have frail patients where we have to perform, at least during a part of our interventions, manipulations and treatment without injection of contrast. We need to really spare as much contrast as possible. What I will try to do in this presentation is to share some examples of how you need to change your mindset and how you can take advantage of technological developments and also of particular skills to perform ultra-low contrast PCI. The first scenario I would like to share with you is a scenario where you simply cannot make injections of contrast because you can ruin the whole procedure. It's a case of a chronic occlusion of the right coronary artery where we consider that the best possible approach probably will be a retrograde approach. As you can see, this patient has diffuse disease distal to the RCA occlusion, has very good interventional collaterals from the circumflex. So at this point, we thought that this probably would be the most likely approach, and that implies that we will be doing CART. And of course, you cannot make injections because you will generate barotrauma. These are the images we obtained in the cathlab with simultaneous opacification of the right and left coronary artery. And here you can see, as mentioned, this diffuseness of disease in the distal part of the right coronary artery, distal to the occlusion. Now, we crossed successfully this collateral. We were able to externalize the wire. And what you are seeing here now is actually a way of modifying the use of sync vision, co-registration of IBUS with angiography. In this case, what we do is to use the guide wire as a surrogate of the vessel lumen. We are not making injections, but as you notice, we use as a center line the guide wire that we have externalized. And in that way, we can perform the pullback of the IBUS, as you can see here, across all the occluded segments. Of course, this was pre-dilated before. And immediately after that, we will have the possibility of interrogating in the co-registration every particular segment, decide from where to stent, choose the stent dimensions, etc. So here's the co-registered images. You can see that I'm clicking on a particular location of the occluded vessel. I can see exactly where are the proper landing zones, dimensions of the vessel, etc. And that's basically what we are doing at this particular stage. So based on this information, we knew that we had to use long stents, of course. This is the predilation, exactly going up to the point where, without the need of making a contralateral injection, we knew that we had a very nice landing zone. We treated also the proximal part. And after stenting, what we did is we repeated the same approach. We traced the center line, again, using the silhouette of the guide wire. And we performed again IBUS to ensure that we had obtained a very good result. So it's a very simple approach. It's a technique that we developed at our institution, but that now we use routinely in this type of scenario because it really is very useful, and it provides enormous incremental value to IBUS, the fact that you can co-register the whole segment and make decisions on revascularization. The final result in this case, as you can see already from IBUS, was very good. There was a lot of plaque in this vessel, obviously a lot of vessel remodeling, but taking into account that we had used 4 millimeter stents, there was no need for performing further treatment of the vessel. This is as you can see, the final angiographic image that we always perform, of course, in order to rule out that there are perforations or any other complications. The next case I would like to share with you is a completely different scenario. Here, the complexity of the patient is largely dictated also by the characteristics of the patient. It's a patient who have chronic kidney disease. As you can see, he had previous CABG, which was non-function. The grafts were non-functioning in the long term, and we had to go for this particular treatment of this difficult bifurcation and also a left main stenosis. So what we did in this particular case is first using the views that we had from the previous angiogram to perform the wiring. So at this point, during the PCI, no injection has been done. We just used the images that we have displayed in front of us from the previous angiogram. After that, we performed a minimal predilation of the left main. We interrogated the vessel to get all the information required for stenting. You could see here that we were having the display of the vessel of the previous angiogram. And we opted for treating with a decay crush this bifurcation in the LAD. You already noticed in the views some of the steps followed for this particular approach to the bifurcation. There was a lot of diffuse disease, so there was obviously no possibilities of getting away by using just a provisional stenting technique. Now, many of these steps were facilitated by image enhancement. You can see in the lower right panel how we were using technologies like stem boost, dynamic stem boost, or even this specific analysis features that are included in the SyncRS package. We also treated the left main using exactly the same type of approach, minimizing the amount of contrast. So only at very specific points, again, to rule out aspects like perforation is when we performed some injections, but most of the case was performed completely without any contrast injection. And again, what we could do, you can see here that the co-registration, like in the previous case, has been done not on an angiogram, but just using the silhouette of the guide wires that we use for the procedure. So we could make sure that the result of the intervention was good. And here are the final injections of contrast performed in this patient. So in total, for this very complex bifurcation left main case, we were using less than 30 millimeters of 30 cc's of contrast. The final example I would like to share with you is a situation where you have a complex bifurcation and you will need to spend a lot of time in addressing this difficult takeoff of the diagonal branch for wiring. We anticipated this. Here we can see the moving images, again showing this difficult bifurcation, which was very difficult to wire using conventional approaches, even with a double lumen microcatheter. It was very difficult to gain access. So we moved very quickly to a retrograde wiring technique, a technique that is extremely useful for this particular situation. As you can see, the side wire has been bended. And what I'm doing now is I'm pulling back the microcatheter with the bended side wire, which is swiftly moving into the diagonal branch, and in that way allowing perfect protection of this. And you can see that all this is performed using dynamic coronary road mapping. So no need at all to make an injection. A single injection performed at the beginning provides a beautiful roadmap to see how your hardware is being used. Actually, it can be used also as a way of co-registration, because as you can see here, we were seeing the location of the IVO sensor at the same over the silhouette provided by the dynamic coronary road mapping. Now, after this, we proceeded in a conventional fashion, and we opted for a provisional stenting technique based on the information that we have obtained. Again, dynamic stent enhancement with stent boost was very useful. And you can see that now we have a pinched side branch, the situation where you really have to make a decision. Here, physiology plays a very important role. We first advanced a pressure guide wire. We perform IFR, so no need to give contrast, fast examination, demonstrating that this is hemodynamically significant. But before doing anything else, what we did is performing POT with the pressure guide wire in place. And here you can see the hemodynamic effect of POT. After performing POT with the pressure guide wire in place, you can see that the IFR has been completely normalized. So there was no need to perform additional treatment in this bifurcation. And this is the final result with an excellent physiological result in both the LAD and diagonal branches. So in summary, in this presentation, we have revisited the use of the number of tools and skills to spare contrast injections in complex PCI. We have actually seen the value of using the pre-existing angiograms to perform wiring of your vessels. You have also seen how we can use co-registration of intravascular imaging with intracoronary guide wires serving as a surrogate for the opacified vessel. You've seen how dynamic coronary role mapping is a very valuable contrast-free reference for difficult coronary wiring and sometimes for deployment of stents, etc. And also the value of dynamic stent boost to monitor stent expansion and to perform accurate post-dilation or stent positioning when you are performing two stent techniques. I hope that all these have conveyed some valuable educational message to you, and we look forward to your comments. Thank you.
Javier, thank you very much for excellent overview. You showed us all technological advancements, and you really showed very complex cases. And I really appreciate to see combined use of road mapping, co-registration in physiology, in the imaging. I really learned a lot from your presentation. But what is your opinion? What is the most important aspect that we need to change in our mindset to adapt to this complex patient population?
Yeah, thank you, Goran. It's a very important question. I mean, obviously, I think that the most important, message is that you need to change your mindset. You know, you need to be aware that you have to change the way that you've been doing interventions for many, many years. The reason is because the patients have also changed over years, and now you're dealing with a completely different population, study population. And you know, once that you have habits and you're accustomed to do things in one way, there is always a small resistance in changing the way that you do it. So at the beginning, you may feel perhaps a bit uncomfortable, you know, because you are not seeing where you are deploying the stent, etc. What we're trying to demonstrate with, with the cases I share, for example, is that you have objective ways of knowing what you are doing. So when you start implementing this type of skills in your way of proceeding, when you start integrating this and any other tools that will help you to perform interventions with less contrast, or even segments of your interventions completely free of contrast injections, that will be extremely helpful, will pay off, and most likely there will be evidence coming in the future demonstrating that this results in better patient outcomes.
Yeah, thank you very much, Javier.
Thank you very much for the invite. My talk is on IVUS co-registration in multivessel disease and in left main bifurcation. And these are my conflicts of interest. So in complex PCI, there's many similarities between climbing a mountain in snow and performing complex intervention. So for both, we need a good roadmap. You need your safety equipment. You need to be able to navigate. You need your team members and tools. And if you run into trouble, you need a bailout kit and the best use of technology. So we do have technology available now of IVUS co-registration, which co-registers the angiogram with the cross-sectional IVUS image. And this is our cathlab control room in Blackpool, where we have multiple pieces of hardware and software in the lab. But really, if you have a new piece of equipment, you want to have a good practical use of the hardware. So this is the first case. It's an 80-year-old gentleman with significant angina on multiple anti-anginal drugs with mild impaired left ventricular function. and he has got CKD with an EGFR of 18. He's had an angiogram performed in the referring hospital a few weeks ago, and as you can see that there's a severe pattern of coronary artery disease involving the left main stem, LAD, and circumflex. And the left main stem has got this ulcerated appearance and tight osteostenosis. So this gentleman was referred for a surgical opinion, and he was deemed to be too high risk in a surgical turndown. He has this pattern of coronary disease and severely impaired kidney function. So we know that patients with CKD, if they develop contrast-induced nephropathy, the prognosis is poor, with a mortality of up to 25% at 12 months. And this prognosis is very poor out to 5 years, with only around a 30% survival rate if you have underlying CKD and develop contrast-induced nephropathy. So it's really important in this group of patients to protect from contrast-induced nephropathy. So if you're on the mountain and then night has set in, we're in a situation of trying to find our way back down in darkness. And this really takes us to this case of whether this is a case for zero contrast PCI and navigating without contrast. So, you know, we've got many challenges, and from a practical perspective, you first have to engage this tight ulcerated left main. And upon engaging the left main stem, we can look at the changes in pressure, and we place up road maps of the previous angiogram that are printed out. And these are the road maps we use to wire the vessel. So you can see we've wired the LAD here. This is the wiring of the circumflex. And we only give contrast injections if the patient has any hemodynamic instability, ECG changes, or unexplained chest pain. And after ballooning the left main stem, we are then able to perform IVUS assessment, and we use the guide wire and manually track the guide wire as your roadmap. And then we're able to perform a co-registered run. So this is co-registration of the LAD, and this shows you the vessel size, it shows you the distribution of disease, whether you require any modification of calcium, and it will allow you to plan your strategy. So we can then measure the distal landing point. You can measure the proximal vessel size and landing point. And this Sync Vision software will also allow you to fairly accurately measure the length of vessel which will require stenting. So we then prepared this vessel and we placed 2 stents in the LAD, and we were able to spare the ostium because we can see on the IVUS that there is no significant disease at the ostium of the LAD. This is the co-registered run post-stenting, and you see that there's quite a good result here, but there's some room for further post-dilatation, which was performed. We then move our attention to the circumflex, and this is a speeded up co-registered run of the circumflex artery. We can see that, again, there's quite a large disease burden, and there's significant disease involving the distal circumflex and this ulcerated plaque in the proximal circumflex. We look back at our original angiogram from the referring hospital, and we can see that these 2 sizable obtuse marginal branches. Therefore, we decide to treat the distal lesion just with a drug-eluting balloon. We now have to deal with the left main stem, and we decide to deal with this with a provisional strategy, stenting from the left main stem into circumflex. And we use a floating wire technique in the aorta to be able to mark the ostium of the left main stem to ensure there's no geographical miss of the ostium. We stent from circumflex to left main stem, we form a pot with a 5mm non-compliant balloon, and then we just open the struts into the LAD with a balloon and perform a final pot. We then do our final co-registered run from the left main stem into the LAD, and you can see a very nice result with good stent expansion, sparing of the ostium of the LAD, and good expansion of the left main stem. And we can see here that the origin of the circumflex and the origin of the LAD look good on the co-registered run. And this was the circumflex post-PCI IVUS runs, showing a very acceptable minimal stent area of the circumflex. So in this case, we were able to demonstrate that the landing, the result from the stent met the ultimate criteria. We know in the ultimate trial, if you perform optimal PCI, the results are very good. And we were able to show in this case that the stent landed in less than 50% plaque burden, and there was stent expansion of greater than 90%, and there was no large edge dissection. So the whole PCI in this complex case was performed with zero contrast. And the question is, do we really need an angiogram? So in our case, we did give a single biplane shot, and this showed a good result angiographically, just giving 5 mils of contrast. And the reason for this is to ensure that there's no distal wire perforation and there's no problem with any of the side branches. This gentleman was followed up at 4 months, angina-free, with no deterioration in renal function. So what if the weather conditions are worse now and you've got really challenging conditions? This takes us on to the next case with a 79-year-old gentleman with stage 4 CKD, severe peripheral vascular disease, who's admitted with a non-ST elevation myocardial infarction and has got widespread ECG widespread ischemia on the ECG. The echo shows moderate to severe LV systolic dysfunction with an EGFR of 17. So this sounds like a familiar story. This was his angiogram, and he's got severe calcific distal left mainstem disease involving the proximal circumflex, and there's also proximal LAD disease and mid-LAD disease as well. And you can see the distal left mainstem is tight with a Medina 111 classification. So this gentleman was again referred for surgery. He was turned down because he was high risk. We have got this severe renal impairment with this distribution of coronary artery disease, in addition with peripheral vascular disease and poor left ventricular function. So this is more challenging. It may well require the use of rotational atherectomy. We're dealing with a true distal left main bifurcation disease. So again, we were able to use a zero ultra low contrast strategy. We placed the roadmaps from the diagnostic angiogram, and then we were able to wire the circumflex, wire the LAD, and then after pre-dilatation of the distal left mainstem, perform our co-registered IVUS run. And we again use the wire in the LAD to track the vessel, and the co-registered run shows the distribution of disease in the vessel, and we can see that the distal left mainstem has got this concentric calcification and quite tight disease. So this requires rotational atherectomy, and we rotablated the distal left mainstem and an LAD without contrast. We then performed an IVUS of the ostium and proximal circumflex, and then decided to deal with this as a DK crush case, but first dealing with the mid-LAD first. And then we performed the DK crush using the standard steps. We stented the circumflex, crushed. This is rewiring without giving contrast into the circumflex, performing the first kissing balloon inflation, stenting the ostium of the left main using the floating wire technique, and then performing pot, kiss, and a final pot. This is the IVUS run from circumflex into left mainstem. You can see good stent expansion, and you will see the LAD coming in there at 3 o'clock. And this is from the LAD into left mainstem, again with a very good stent expansion there. And we see the origin of the circumflex coming in at 4 o'clock. We did one single angiogram with 4 mils of contrast, showing a very good results. So we know the use of intracoronary imaging can significantly reduce the volume of contrast used in coronary intervention. There are 2 small series, one by Ziad Ali in the States and one by Professor Dudek, showing that this is a feasible technique, and in patients who undergo ultra low or zero contrast, there's no deterioration in renal function. And There's also evidence showing that if we do use IVUS-guided minimal contrast intervention, this reduces the requirement for renal replacement therapy in patients with underlying CKD. So there are some new kids on the block. Solution X has been under production for use of OCT and no contrast use. There's Renal Guard, which is a fluid management system, and there's some emerging evidence that Impeller may also protect kidneys. So going back now, we navigated our way in darkness from the mountain, and this is very similar to navigating your way in darkness doing zero contrast PCI. It's very important that you use the right technology, and for both scenarios, you need the right team members. So in conclusion, IVUS co-registration is useful in zero contrast or ultra low contrast PCI in complex coronary disease in patients with CKD. It is feasible to perform complex multivessel PCI in these patients, and it's also feasible to perform complex distal left main bifurcation, including DK crush with zero contrast. And is this a new role for IVUS co-registration in the CKD patient? So is there a strong role for renal protection in IVUS co-registration? That's the question. Thank you.
Billal, thank you very much for excellent case examples. It was really impressive for me, especially the second case in which you perform plaque modification with rotablation, and after that one of the most complex two-stent strategies, double kissing crush for distal left main bifurcation. And all that was done with zero contrast, solely based on IVUS co-registration. Having in mind today's talk of limiting the use of contrast and the patient population with large burden of disease that you see definitely in your lab, in your practice, can you please elaborate on specific issues and troubleshooting in those procedures?
Sure. So I think, we're dealing with a very, very complex group of patients. In troubleshooting, it's really important to get the balance right between not giving any contrast at all versus knowing when you would need to give contrast, and it's balancing the safety of a very complex procedure versus protecting the kidneys. In troubleshooting, we found it's really taking time when you're mapping out your guide wire for the co-registration and making sure that you do the IVUS pullback very slowly and you cross-check it afterwards to make sure that it has co-registered accurately is really important. Once you've got your co-registered run, actually it gives you a lot of confidence in doing the rest of the case without giving contrast. And so, for example, in the left main case with rotablation, without giving contrast, we were confident. We knew the size of the vessel, we knew the distribution of the calcium, we knew how distally to go with the rotablator. So it is pushing the boundaries, but I think as you develop the experience, it gives you the confidence. And this, there's a large burden of patients out there with very complex disease and renal impairment, and we know that this population is underserved when it comes to coronary angiography and revascularization. This group of patients could benefit from this technology to allow us to safely perform complex intervention and protect the kidneys at the same time.
Thank you very much both for great presentations and for sharing such a complex cases. It's obvious that we have a shift in patient demographics, and probably in the light of recently presented ischemia results, Javier, please elaborate on how ischemia results on the impact on hard clinical endpoint has influenced your practice.
Well, I think that, it has already, so to speak, generated more awareness of what we already knew from Courage and other studies. I think it will affect us much more when this translates into recommendations from clinical practice guidelines. But the point I will make, Goran, is that probably, the consequence of implementation of the findings of ischemia, so to speak, is that we will have a shift also in the type of patients we treat in the cath lab, and we will see more and more the type of patients that we've been discussing today. In other words, my impression is that those patients in whom we are going to consider now first medical treatment as a valid alternative to interventions will be patients with much lower risk. And you will be referred many more patients that have a very complex profile, that where medical treatment can be a problem because there are concomitant conditions, because the patient have refractory angina, because they have severe, coronary artery disease that perhaps is not amenable for surgery due to the characteristics of the patients, etc., etc. So I think that in a way, I think that what we'll have is a case selection in the future caused by the conclusions of the ischemia trial, and as you say, a higher number of patients dictated by the shift in demographics and the fact that we are doing patients with much more advanced disease.
Billal, what is your opinion on that point? What do you think? Yeah. How do you expect your practice will be influenced by the ischemia results?
So, I mean, I think we're already seeing a far more complex group of patients, far higher risk now for PCI. And I think the more complex intervention is done on the more appropriate patient now. And so I think the use of these technologies will definitely be increasing. And I see, more the high risk PCI programs developing in many centers now. In our own practice, we've seen a huge change really over the last 18 months in far more complex patients referred for PCI, which, in the past may not have had revascularization.
Tell me, in both of your presentations, you tackled mainly patients with already impaired renal function, with chronic kidney disease. Are there any other patient subsets that you see as a potential candidate for use of new technology developments, and in order to decrease the amount of contrast that we are giving in our regular PCI practice?
Well, in my experience, or our experience here at Hospital Clínico San Carlos, what we've seen is that once that you incorporate into your practice these skills and these technologies that we have been discussing in this session, is something that you start finding useful in many patients where before you would not anticipate, that were deemed to be treated in that particular way. So as I mentioned before, I mean, you may have the patient that has impaired chronic kidney function with chronic kidney disease in the long term. This is a very typical situation. But of course, what would happen in many situations is that you will have complex PCI procedures where a segment or a part of the procedure will benefit from not performing injections of contrast, and where monitoring the advancement of the procedure in terms of stent deployment, expansion, etc., can be facilitated by these adjunctive techniques.
Thank you. Billal, what do you think, how this will impact your practice?
Yeah, so I think, one big sort of revelation of using minimal or ultra low contrast is in standard PCI. You can probably do the case using far less contrast. And so I think it does change your practice for other cases. Another use of co-registration we found particularly useful is in targeted modification of calcium, particularly with the advent of lithotripsy. You only have 80 bursts of the balloon, and if you've got a heavily calcified vessel, the co-registration can allow you to target specifically the areas where you can get the most efficient use of a shockwave balloon.
Yeah, thank you very much both. This was extremely useful, and I believe that this session really showed us the way to proceed to pre-select broader patient population with much more complex disease. And after a learning curve with use of these new advancements in technology, I'm sure that we will be able to expand our practice to much broader complex patient subsets, including surgical turndowns. I thank you very much for sharing this with us. Thank you.
Thank you very much.